Tesla scanner as well. So don't spoil it if you're doing cardiac at 7 Tesla yet.
But to get the free breathing, you need to increase the number of averages you do.
So you're just talking about implants. What about scanning pacemaker patients?
Oh, pacemaker patients are usually the funny one. From a congenital perspective, but also for adult, it's just like you have one sequence with which you can see the whole flow.
So what's your suggestion for a radiographer that approached cardiac MRI for the very first time?
Keeping the shin box as small as possible around the heart, trying to avoid as much as possible air, both from outside the body of the patient and then from the lungs.
So I think the opportunity you had was one of a kind, basically.
Yes,
it's not something that you find on LinkedIn jobs or anything like that.
Not.
Filippo, listen to me. How can you do like a stress perfusion remote?
Well, 055 has the same problem that the 7T, which is the ECG again, starting off.
Filippo is also a research radiographer, and here we open another word. Filippo, the day has come finally. Everyone wanted this moment. Us talking about cardiac a little bit. I mean, since we opened this page, this company, the social media of Everything MRI, we have received a lot of messages from people asking, when are you talking about cardiac MRI? How can I do this in cardiac MRI? So yeah, I think it's been quite a topic that we have discussed very little, but the interest is massive. We actually made a few videos just discussing a little bit the planning of cardiac MRI sequences, but I think the time to have a guest here discussing every single aspect in cardiac MRI has finally come, and we have you, and I'm kind of like super happy about this because I know you are a cardiac expert, and I want to start from here. To be honest, I think you have a very peculiar journey because you are the only radiographer that I know that started straight away working in cardiac MRI. Not even X-ray, not even CT. You graduate and then you went straight to cardiac MRI. How is that even possible?
Well, it's been a journey, as you said. It's all started in Italy, where I got this offer essentially to come to London just to learn cardiac MRI, because here in UK, as you know, there is banding, so you need to do band 5, band 6, band 7 before, and cardiac MRI is usually band 7 radiographer. Mine was an internal project, I think, of the hospital, just to have someone coming and after university and do just cardiac MRI and see how he developed and everything else, which I think it went quite well. And but because they cannot hire band 5 or band 6, they asked from somebody coming from abroad. So I got this offer, which was very good, and then I accepted it. It was at the beginning a 6 months training post, and I thought it was a very good opportunity essentially to learn something that in Italy was not developed very well yet. And then so I accepted, and 6 months is now 10 years next year. So it's been,
you've been in London for 10 years now.
10 years now, and always in the same department, only in cardiac, and always in the same department,
same hospital,
yes,
same
exactly.
everything.
Same everything, yes.
That's amazing, yeah.
The only difference is that, correct me if I'm wrong, now you are the deputy lead, we call it deputy superintendent here, for the cardiac MRI department, yeah?
Yes, correct. So I started as a training post, not knowing anything essentially, and my career has progressed since then.
I want to mention something about the place where you work actually, because it's very renowned. It's King's College London, and we know that in your department you have how many scanners?
I was not ready for this. I think 6 or 7 essentially.
6 or 7, okay. And I know you mainly do cardiac, just
Yes.
with those scanners, and I think, let's say 10 patients, 10, 12, maybe less than that for every scanner?
Per day, yes.
Per day,
roughly,
yeah.
yes.
So I would say like probably around 60 cardiac patients per day. Is that correct?
Yeah, more or less, depending on the day, but
Wow.
yes.
How big is your team?
We are 13 radiographers.
Yeah. And I know you have different magnetic field strength. You have, this is a kind of, again, very peculiar. And that's why,
No, it's fair.
weird character. But you also work in a weird place because you do cardiac with 1.5, and so far so good. 3 Tesla, and then people might say, wow, cardiac at 3 Tesla. Is it actually suggested, possible? And then you're doing cardiac at 0.55.
We just started, yes,
You
but
just
yes,
started.
yes. So we don't do cardiac. We're still
Yeah.
under research in some way,
Yeah.
but yes, we
Because
started.
this is obviously a research facility as well. You run a lot of research as well and about cardiac as well. And you have a 7 Tesla scanner as well. So don't spoil it if you're doing cardiac 7
Okay.
Tesla yet. But let's start with the 1.5 versus 3T. Firstly, my first question for you is, which one do you prefer?
Well, it depends on what you want to see for in a patient. So why the patient is coming for a cardiac MRI. If it's mainly a coronary pathology, so which the patient requires a stress, 3 Tesla win like with very low hand. While if instead we are talking about a general scan, probably 1.5. From a radiographer perspective, it's easier on a 1.5 because require less shimming. But yeah, 3 Tesla for stress patient is actually the master essentially.
Okay, this is quite
May I
interesting.
just say something? You were talking about pathology as well. Which one is the most common pathology that you get at your center, and which scanner do you use most often to cover that pathology?
We got a lot of patients arriving with troponin raise, so suspicious of potential myocarditis. That's one. A lot of coronary artery disease. That's I think is the main two, and then obviously like people with chest pain and
You also
just
do
coming for-
congenitals as well.
We do congenital as well. Yes, we have about 12 congenital patients
Okay.
per week.
And
So, sorry to
No, no,
interrupt.
go
So, just to go on that line of the congenital, if someone listening at home that wants to start cardiac and they don't know what a congenital is, and what's the difference between a healthy heart and a congenital?
Well,
Can you describe that for us?
Oh yes, of course. Congenital patients are patients that have born essentially with something anomalous within the heart, and so they had an operation usually when they are really young, even when they are literally babies, and then obviously because of their operation, we need to check how the heart is doing. During their lifetime,
So
essentially.
they need follow-ups
Oh
throughout
yeah, yeah.
their whole life.
Yes. So they
And
start. Sorry.
That's usually harder to scan, right?
It's I would not suggest anyone to start with congenital patient first, but always with normal heart, I would say, and then moving over to congenital. Because sometimes, like they have, I don't know, the systemic system starts from the right instead of the left.
Okay.
As per normal, they have the heart on the right side instead
So
of the
situs
left.
inverso as well.
Yes, exactly.
Wow.
And then yeah, there is a lot of pathologies to be honest.
That's
So
good. And I think most of them are scanned without contrast. Correct me if I'm wrong.
the congenital patient are usually can be without contrast. Main reason is because we're not looking to see if there is any scar.
Yeah.
And the other reason is because if we give contrast every single time they have an MRI, some patient has an MRI each single year, to be honest.
Yeah.
So there is no study proving that the contrast is affecting the system or anything else, but there is some proof about the pituitary gland and accumulation in the pituitary gland and everything, so it's not ideal.
Okay. Yeah.
If it's not strictly necessary,
this
we
is
avoid to
absolutely
give
clear,
contrast at that
I
point.
think this can be applied also to other type of
Yes,
scans.
exactly.
And just to go back to the comparison between 1.5 and 3T, I was actually quite curious about this. You mentioned stress perfusion at 3T. I think someone wanted to ask you also how you do stress perfusion. But firstly, what is the main advantages, of doing like stress perfusion at 3T? This is one of the questions that we receive quite a lot. Is it the SNR that you have?
Oh yeah, you have an amazing SNR, and then it's very good to see microvascular disease, which instead 1.5 usually miss.
But is the sequence itself?
The sequence itself, it's obviously more or less the same. It's the signal that it's much, it's greater on the 3T, giving like obviously better visualization. Now they're developing also maps for the stress perfusion, which will help also with the diagnosis.
I think also generally now, we can say this, we work together obviously, and I think we can actually spoil it.
We have to say,
Actually, I remember that on that scanner, that 3T scanner, I think also the late gadolinium announcement at 3T was particularly nice. It can be challenging a little bit, but yeah, sometimes for patients that we're collaborating, I can see your face. You might not agree, right?
Yeah, I do partially agree. On 3T, sometimes, I mean, it's usually better, but not always. It depends a lot on the patient, if the patient has an implant or anything else, because obviously you get more artifact. And then if the patient is in AF, atrial fibrillation, so it doesn't have, is not in sinus or is not able to hold his breath, usually instead 1.5 there. It's a bit better, but mainly I think from implant perspective,
So
obviously.
you're just talking about implants. What about scanning pacemaker patients?
Oh, pacemaker patients are usually the funny one. So we usually do the pacemaker patient on the 1.5 for that reason, because obviously we have much less artifact. The structure we have at King's for pacemaker patient is mainly on the radiographer checking if the pacemaker is MRI conditional or not. And there is an amazing website called My MRI Pacemaker in which you can just check everything very easy over there.
We know about one of our partners called North Insight. They actually have a platform where you can check all the implants.
Okay, fine.
I didn't know about that, so it's good for everyone to know there's another one that we can use.
I think it's mymripacemaker.com or .co.uk. I'm not sure about that.
We'll leave it on the description later on.
Exactly.
Good.
And then so we check if he's MRI conditional or not, and if he's not, we need to proceed with an off-label procedure, which is another level of bureaucracy, essentially.
For that? So you have an
we
SOP
have an SOP,
for
yes, of course.
scanning.
Yes.
That's awesome.
I was part of the team rewriting the pacemaker one, which has been approved, I think, 2 weeks ago. So it's a very, very fresh
And
again.
do you do those pacemakers just on 1.5? You don't do them on the 3 Tesla?
No, because the artifact will cause too much trouble, I think, and then the image quality is not going to be
Is
there.
it just the artifact, or also the fact that some of them might not be compatible at 3T?
Oh yeah,
even
no,
after the
obviously,
pacing check?
if yes, of
It
course.
might be a little bit of both, actually. I
Yeah,
would say.
it could be both. Because I think I came across some pacemakers that they were actually conditional up to 3T.
Absolutely.
So I was actually wondering, actually we had the possibility. But yeah, I think the artifact would be detrimental, to be honest, for the image quality.
He's already at 1.5, to be honest, for some patient. This is why you need to adopt positioning for patient like.
I think once you told me some tips and tricks to get good image quality with pacemaker, I think some people might be interested about this. What do you do?
So we usually position the patient as per normal, so arm by the side, and then we perform the localizer. And it all depends where the pacemaker is, to be honest, because if it can be in the pectoral region, it can be a little bit more on the side. So we perform the first image. One trick you can use for pacemaker is just asking the patient to keep the arm above the head. That will move the pacemaker away, essentially the main box away from the heart, which is the anatomical region we are interested in. Although keeping the patient with the arms up is not the most comfortable position. So obviously in cardiac MRI,
together might be hard to do, I would say.
And 45-minute scan can be detrimental for them. So that's a trick in any case. And then we start with the normal cine that we normally do, the BSSFP one. And then if they're not good enough because there is too much artifact, we then proceed with an increment of the bandwidth within the sequence. And again, if that one is not working, we move then to the gradient echo sequence, flash sequence for the machine I'm using.
What you do if a patient has a pacemaker on the back? I'm asking this because my grandfather had a pacemaker and he had to replace it 3 times.
Wow. Okay.
And he had it on the left side, then on the right side. Then they tried to put it on the belly. They couldn't, so they put it on his back.
Wow.
I didn't even know it was possible.
I know, me neither, to be honest.
Because I've never done one of those.
Did you encounter a patient with a pacemaker on
No,
the back?
it's the first time here.
Okay,
something
is it your
similar,
grandpa?
so.
My grandfather, unfortunately, he passed away.
Oh, no, I wanted actually to tell you, get him on board. Okay.
So I had another question, if you don't mind, just to rewind a little bit when Julian was talking about stress perfusion. And we talked about that you have a 7T scanner. And we spoke on the background that you're not doing cardiac there.
Yes.
But my question is, we're moving more and more to do stress perfusion on 3 Tesla. What do you think about 7 Tesla? Would that also be something that we can move forward to? Or you think there's too many complications at this point at 7 Tesla to go
As far as I'm concerned, there are gonna be at the moment there is too many complications. First of all, getting a diagnostic ECG. So obviously you can perform a scan without having an ECG, and 7 Tesla is still in development for that. It's from a safety perspective, there is a lot of restriction over 7 Tesla. Like for example, even dental implant for patients, some of them are not compatible because they can break the capsules.
What about the retainer? Is that also an issue?
Retainer, I think they should be okay, but it's not my field. So I know about because I did a couple of research about that, and then some implant they can break essentially and leak the liquid inside.
This is super interesting, to be honest. This is super interesting because if you think about it now, the approach is, well, most patients when you come with the safety questionnaire will say, well, I have feelings, I have dental. You say, no, you're absolutely fine.
Exactly.
Can you imagine if you have to redefine completely your way of working? Oh, do you have feelings? No, wait, don't move over there.
I think the higher we go, more complex it becomes. And you were just talking about the ECG, and we know they miss triggers sometime on 3 Tesla, so I think it's going to be already an issue as soon as you put a patient on 7 Tesla.
I think so, yes.
But is it the noise on the ECG? I mean, the R wave and the T wave?
Yeah, I think he's not reading correctly. I mean, it's fine, obviously, if there is no radio frequency impulse, but as soon as you start to obviously scan the patient, then the ECG
that's when he mistriggers.
Yes. Wow, that's very interesting.
But again, it's not my field, so it's it needs...
Absolutely,
Actually, someone actually gave me a very interesting assist because he said, and I would say correctly, that we're trying to push to go, up with the magnetic field, but at some point your hospital decided to go down. So they decided to get like the 0.55. I was like, wow, what is this change of direction? So there is this helium-free scanner. Correct me if I'm wrong. Nearly free. And that, interestingly, you're using for cardiac research. I saw some potential result as well. I will give you my take, but then obviously you give me your feedback, which is the most important one. I think for follow-up, for the images I saw, it might be a good option. Would cardiologists get used to it? It seems a little bit too poor of a scenario, in my opinion, maybe. So I doubt it. They would do it in a clinical practice. But I would say for a follow-up patient, like a congenital that might come like years after years, that one might be a good option. But tell me more about it.
Well, 055 has the same problem that the 7T, which is the ECG again, starting off, because the 055 is a machine which is not being created for cardiac. So we don't have a proper cardiac gating coming from the manufacturer. Hence, we do an external gating. So we attach a machine which connect to the main machine for the gating. And that's causing
just
already...
like a vital signs monitor.
Yes, exactly. And so we can get the ECG, and the ECG connect with the machine so we can scan. But that caused the first layer of problem of just like it's not part of the machine itself. So if the patient move radio frequencies, does interfere with the scanning itself. Regarding image quality, I have to say I started the 055 I would say 7-8 months ago now, and image quality has improved massively. But I do agree with you for if there is like a small scar, suspicious of a small scar, it's still not like the greatest machine to scan this kind of patient. None of the sequencer product at the moment, hence is all research. So patient needs to consent to come to have a scan on the 055, and we usually do that on 1.5 or 3T and then on the 0.55.
So you inform the patient in which scanner they
we
have
ask
in their
them
exam.
To come back, so they have the normal clinical scan and they come back for the scan on the 0.55.
So that's the research part of it.
Correct, yes.
Okay, so they have their scan in the 1.5 or 3T, and then they have another scan. Okay, that's fine.
That's very interesting, actually, the way you set it up.
Yeah, it's really nice. And then obviously there is all the problem for the implants, because all implants are conditional at 1.5 and 3T. Absolutely. But there is no official rules for the 0.55.
That's one of the conversations that we need to have in the future, because implants are massive now. Everyone has implants. And they're all labeled for 1.5 and some of them for 3 Tesla. And then
correct me if I'm wrong, we have touched base about this during the forum as well. By the way, thank you for whoever attended the Everything MRI forum, which was a great success. And we were a little bit stressed, but thank you. And I think we very briefly touched base about this. And as you're saying, some implants might be compatible at 1.5, but is it actually mentioned if they will be compatible at 0.55?
You have to scan off-label basically
Yeah,
all
correct.
the time.
They're all
It's
off-label.
like an open
essentially.
scanner.
Yes.
It's also off-label. You have to do it the same way.
Yeah, exactly. We're now doing a lot of SOPs about implant for as soon as the physicists are happy essentially with that. But like cardiac monitor, like reveal device or pacemaker, obviously are still a massive no at the moment on.
So on top of that, actually, you were talking about the gating. So there's retrospective gating and prospective gating,
Yes.
and also free breathing. Which one you think is the best and why? And if you're scanning on a 1.5, which one you choose? If you're scanning on 3 Tesla, which one you choose? What's the rationale for you to choose one or the other?
It depends on the patient, essentially. We usually scan all the cine in retrospective gating, and then you move to prospective in the moment the patient has, for example, atrial fibrillation. All the 𝐊𝐍𝐼 sequence, as well as the T1 map instead, are prospective because you need to trigger a specific part of the cardiac cycle.
Yep.
Free breathing, I have to say now the late guard are all free breathing.
Really? Even like the long axis, all of them?
All long axis
Yeah,
and
we
short
also do it
axis.
that way actually with the rest scans.
Correct,
We
yes.
do the late gap with the free breathing.
And it's very good. I have to say, image quality is amazing.
So they have the motion correction.
They have motion
yeah.
correction, yes, exactly. So prospective gating is very good if the patient is not in sinus. So if he's in AF, and then obviously the machine is struggling in triggering, and then the picture become very blurred essentially because you can distinguish.
Just to clarify this, because this is one of the questions we have received like many times. So what's your suggestion like for a radiographer that approached cardiac MRI for the very first time when they have to deal with like a patient who has arrhythmia, for instance? How do you start? You start with a retrospective and then you move to something else?
I would say so, yes. It's become, you need to have a little bit of an eye, I would say, on that one, because you need to understand that when doctor essentially draw the circle to make the final diagnosis, they need mainly they need the systolic and the diastolic phase. So you need to be able to see both. If you're not, because obviously there is too much motion due to the incorrect gating, because the patient is in AF or has ectopics, the first I would say always start with the retrospective and then move to prospective as a second option.
Do you try free breathing as well for the cines?
Free breathing for the sinus if the patient is not compliant with holding his breath, essentially. Free breathing with arrhythmia. I actually had a patient today, and the picture came up quite good.
I actually wanted to ask you this because I know that some radiographers in that specific hospital, they might suggest you a different thing, meaning that if a patient has arrhythmia, they move from retrospective, they skip the prospective part, they go straight into free breathing, which apparently some of them claim you might get better image quality.
But to get the free breathing, you need to increase the number of averages you're doing, so the number of cardiac cycles you are triggering, meaning you're going to have more motion. I'm not in total agreement with that. To be honest.
That's why we have this conversation.
You need to discuss with your team.
Can I ask another question on top of that, actually? So there's actually two questions in one. So one of them is the free breathing question. With the advancement of AI, I believe I've read a few articles that we're trying to move as much as possible through free breathing scans. What's your opinion on that? If you believe that's actually going to happen?
Free breathing scan, I have to say, so depends how you're doing the free breathing. If you're using real time, there is a lot of discussion and contrast within the cardiologist about that, because the position obviously change depending on the patient breathing and everything else. If you intend free breathing with an increment of the averages, you need to also think that obviously you are increasing the time of 3-4 times. So, and cardiac is not already a short type of scan, so you can get to have 45-minute scan just for doing function and guard, which might not be very good for all patients, I would say.
Yes, apologies. But what I think was also he's asking, what if you have algorithm like deep learning?
exactly.
Oh, yeah,
are
no,
you
yes,
able to
okay.
accelerate a little
reduce that
bit?
time.
Oh, yeah, we use a lot of compression sensing at the moment, which is
Yeah.
obviously accelerating quite a lot, and it's very,
Yeah,
very
so
good.
parallel imaging.
Parallel imaging.
And do you have also like an AI software integrated in any of your scanners that you're using at the moment?
Yes, we do. Yes, it's
Yeah.
a deep resolve one, and then, as I said, coming with the compression sensing, and then making the scan much more shorter.
Does it allow you to? Yeah, does it allow you to accelerate a little bit the cardiac
Yes.
scan?
Oh, yeah, no, massively.
Because I think usually we tend to associate this type of scan as one of the most complex and advanced for the patient as well, because they have to hold their breath multiple times consistently and efficiently.
Sometimes for an hour or more.
Yes, sometimes
Yeah.
for an hour. So I think the idea of reducing the time of scanning is pretty important in this field. So do you think, obviously you require more time? I think. Did you have the software recently? Did you have it installed recently?
Yeah, I have to say it's funny because I start back in 2015, where I had where the single breaths for a long axis was about 14-15 seconds, and now we are dropped down to 6 seconds on
Wow.
the most
And
recent
you
machine.
do
So
inspiration or expiration?
we tend to do everything expiration. There is study proving that
Expiration.
Yes.
Is that because when you do it inhale, the pressure on the that you built in is it worse for the patient to hold it, or
you have
what's the
more air
reason?
in the lungs, which can be creating more artifact essentially,
Okay.
and that's one reason. Then there is a couple of study saying that doing in expiration, essentially, you have the heart more or less always in the same position compared to inspiration, because obviously when you are in inspiration, you take much more air.
Yeah.
So
Yeah, and you never do basically the same level of inspiration. Basically, you can do a deep breath hold, and then the next one is just a small
one, correct.
Absolutely.
But what's the best practice always in cardiac, it's instructing the patient. So what I always do before starting each scan is just trying the breathing instruction with the patient a couple of times. It's very
I think
useful
it's great.
because
Communication is key.
yeah.
So yeah.
Because most of the patients have to say, like, they do breathe in, breathe out, hold your breath, but they keep breathing out up until, like, the lungs are completely empty. So they don't stop when you say hold your breath and then your sequence starts. So that's coming from a little bit from experience of just, like, you need to stop straight away when I
So you
said
train
hold your
with them
breath. Yes.
right before starting
Correct,
the scan.
yes.
I think that's a great approach, to be honest. Yeah.
absolutely.
It works the same way with claustrophobic
Yeah,
patients.
correct,
We just
yeah.
train them and then we go and do it. Yeah,
I
awesome.
was actually reflecting on the fact that I wonder if AI will allow us to reduce a little bit those artifacts you mentioned at 3T, and 3T will become the main, like the most used, like magnetic field, the most approachable magnetic field for cardiac MRI. I wonder that, to be honest, because I mean, based on my memories about cardiac at 3T, the image quality wasn't too bad. One of the major issue was shimming, to be honest. And I think this is a question we have received quite a lot of time. What do you recommend to improve the quality of those cines? Cines, I think, is one of the major issue in cardiac MRI at 3T. Not sure if AI will help. I think has been helping quite a lot in different fields. Like, if you want to mention later on, I think you have been using a little bit the auto align as well.
Yeah.
Using AI a tiny bit. There is a possibility to get that one as well.
Yep.
But yeah, I haven't heard yet about AI in cardiac MRI sorting out all this kind of like radio frequency artifacts or dark bending. So I don't know. Do you have like any tips and tricks, any troubleshooting?
Flow artifacts as well, I think.
Flow
it's quite a
yes,
big one.
yes. It's all coming under, I think, like a bit of the shimmings and the knowledge of what to do with the shimming. So trying to keep the shim box as close as possible to the heart, avoiding any hair coming
So
from...
we're talking about active shimming.
I mean,
basically.
active shimming, yes.
Just to make it clear.
Yes. No, sorry. Yes, absolutely. Keeping the shim box as small as possible around the heart, trying to avoid as much as possible air, both from outside the body of the patient and then from the lungs. That's the first trick. Then you perform the first image you see is not good. You have then at that point 2 routes that you can follow. The first one is try to reposition the shim box, possibly parallel to where you see essentially the flow acceleration.
Okay. Yeah.
So where you see the artifact, which most of the time works. And then obviously if that one is not work, you approach like what is called a frequency scout. So you check which are the correct frequency for that specific patient, and then you scan all the scene with that frequency.
Okay, so you're basically shifting the artifact away, right?
Yeah.
From
Correct.
Oh, wow.
The same way when you move the arms up, you shifting the
Position
pacemaker
pacemaker,
artifact
yeah.
away of it. So let's say you move to a 7 Tesla. I know you're not doing it, But let's suppose, what would be the problem with the flow artifacts there?
I think it would be
It would be
greater
even
than,
worse.
Yes, than
Yeah.
3D.
And I have another question. I don't know if it's relatable, but one of my colleagues that works with cardiac, he asked me to ask you this, so I'm going to ask you. He's asking if DSI tractography is routinely done, or if it's more of research tool at this point, and if you do it or not.
I never heard of it, so I
Okay.
would say no, we don't
Yeah.
use it.
That's fine, no problem. yeah.
That's fine, not a
I
problem.
think it's kind of rare, to be
Yeah.
honest. So I've never done it, never seen it. He's just interested on it, so I believe that's why he
Absolutely,
asked,
yeah,
so
yeah,
we
yeah.
could learn as well. But
I actually need to ask you.
None of us
now,
know it.
what's that, to be honest. It's going to
Yeah,
be
Okay,
the other way
let's
around.
invite him. Let's get him on.
no, he doesn't know too. That's why he was asking.
Okay,
Yeah.
well, there you go. So we have the possibility now. Can you just repeat? Can we
It's
just ask
DSI
someone from the
tractrography.
audience? Say it again.
Yeah. DSI tractrography is the same thing that you do for the brain.
Yeah, for cardiac MRI.
But it's for cardiac. And you can,
Ah.
I've seen some pictures, because when he asked me, I was just like,
Okay.
okay, what is he talking about? So I went straight
Wow.
away to read some papers, and it's awesome.
the DSI or DTI?
DSI.
Okay.
So I thought it's the same thing, but I don't know if that's
Okay.
wrong.
Okay. People
we'll
from
see.
the audience, please.
Just comment and let us know.
Come and help us. We need
let
to
us
learn
know.
more. We told you, I think, the very first episode, we're here actually to learn more.
Absolutely.
That's
yeah.
why we invited Filippo, and that's why we wanted to learn more about this. But yeah, if someone knows anything about this, please come and
Yeah.
assist us. To crack on with what we were saying about the cardiac as well, there is one bit that I wanted to ask you on top of this. Now we have asked you many questions about troubleshooting. Is there anything you would strongly recommend to someone that wants to approach cardiac? So someone that hasn't started yet, someone that wants to learn cardiac, because I mean, some of the query we have received is like, do I need to attend a course? Is there like a cardiac training somewhere in the world that I can attend? It must be an in-house course. It must be an in-house training. So what would you recommend to someone who wants to
I
do
had that
cardiac?
question as well. If a student or someone that just finishes their degree and they want to do what you did, start straight away with cardiac. How you go about that?
I would say attending a course would be useful at the beginning, but you need to. We are radiographer at the end of the day. Our work is very practical, so you need to be at the scanner and then being able to scan as much as possible in order to learn cardiac. My career here started as just an observer for 2 months because I was waiting for the registration, and then that was useful because I learned a lot of tips and tricks essentially, but without doing it every single day I realized that I was missing something essentially.
Okay. So I think the opportunity you had was one of a kind, basically.
Yes,
It's not something that you find on LinkedIn jobs or anything like that.
Unfortunately, no.
And do you know any courses that you could suggest? I know one in Southampton which is quite good, quite hands-on.
I don't think they're running.
They're not doing it anymore.
I'm not sure.
I've done it a few years ago,
Yeah.
so I don't know. Do you know any courses that you can suggest for someone that's just trying to get into cardiac scan?
The KCL run a course for radiographers. We also SCMR now. It's we are actually, because I'm involved in that, doing some. How's it called? It's not podcast, with some presentation about essentially cardiac MRI, tips, tricks, anatomy, and everything else.
Planning as
planning
well.
and
Yeah.
etc.
But it's not a certified course, basically. People can just go and watch it, or is it actually you can
you
get a
need-
diploma or something like that?
No, it's not certified course, but it's a really good course. I mean,
Yeah.
the SMR one.
I think this is what we have at the moment, meaning like very good places, very skilled like places to have like a lot of radiographers that are running very useful courses. I think we don't have like a specific qualification
something certified for it.
something certified, and that would be an interesting thing. I know universities are kind of like now getting
Postgraduate plan or something like that?
in their postgraduate, like in MRI, they have the cardiac module
Yep,
now
yep.
because I think they have realized it's pretty like
It's
so
more
tough to-
like master's level, right?
Yes, but still, I mean, you would have a master perhaps in MRI, but there is not like qualification.
There's just
like,
one component about cardiac.
W-
Yeah, I agree.
which is weird because we have the role, at least in the UK, as cardiac MRI radiographer. But yeah, you're an MR safety officer, right?
Yes.
So technically, you are qualified as a.
But I did an exam and I have a
Yeah, this is what
certification,
I'm
and that's
saying.
where I was
Yeah,
saying
yeah.
you should
there is
have something like that.
yeah.
For example, if you want to do mammography in UK, you need to actually do a post-graduation, and correct me if I'm wrong, but I believe that's the way to go. You need to do a post-graduation on mammography to get a diploma to actually do it. So when we do cardiac scan, it's all about in-house training. So if you get a new radiographer coming and you have to teach them, so that radiographer will have all the knowledge and skills that you have, but it's not something that it's basically certified for any board or any...
This is why what I think SCMR is trying to look at.
To achieve,
Yes.
Yeah, you're part of the committee, right?
I'm part of the committee.
Tell
yes.
us everything about it. How you got there.
How you got it?
What
Yeah,
is
please.
it and how you got there.
How can I get like cheap? Please, right?
I have to say it's has been like I'm part of the committee since last year. I am submitting a paper to SCMR since 4 years more or less. And the technology track is quite new as well. I think it has existed since 3 years. Last year was the first one in person, because obviously 2020 and 2021 we won't remember what happened there. And then there was this technology track, and then I approached essentially the whole committee and then asked if I can participate, and obviously I have a little bit of cardiac knowledge, so they were just like very welcoming, I have to say.
So I can see you are one of those people that you look for your opportunities. And
Yeah,
that's what you've been doing so far. And I believe that's one of the good advices that we can give to someone that is pursuing cardiac.
Yes.
If you want to learn cardiac, you have to pursue that knowledge. You have to look for the courses. You have to look for people like yourself and try to speak to them. So please connect with Filippo.
Very happy to reply.
On LinkedIn, if you're happy to just help
Absolutely,
out people.
yeah.
Just
Very
guide
happy.
them in those
Let's
directions.
not forget, guys, that Filippo is also a research radiographer. And here we open another word. How is it possible to be a research radiographer? Okay, so what is firstly being, how it is firstly like being a research radiographer?
Yeah.
What are the tasks? Because many people say, well, what is actually doing a radiographer in research?
What's the day like?
What's the day like? So what do you do?
Depends on your type of involvement in research, I have to say. I remember when I started, it was mainly looking at data and spreadsheet and this kind of stuff. And then it developed a little bit more with the researcher we have. Well, our is one of the biggest research center within the UK. So we have researcher approaching us, trying to develop a new sequence, for example, for cardiac MRI, trying to improve some of the sequence, making a little bit better. I can't talk, unfortunately, much about that, because obviously there is a secret about that. But try to improve research. So part of your job daily, it's try to accommodate this research, because a researcher might looking for a specific patient in which to run that research, if maybe a patient with atrial fibrillation, or maybe a patient which needs to be completely normal, or patient which has a scar. And then from then onwards, essentially, it's part of your job is just like identify the patient and say, oh, this patient could be good for this research, and then you do the research on that specific patient.
So how do you recruit the volunteers to actually go?
So we recruit patient, because volunteer it's instead another part of the research. We recruit patients every single day, because we have an ethic which has been approved for patient to be recruited for extra 15 minutes images. And I have to say, patients are really keen, and this is something that I really
So they have their clinical scan, and then if they sign that specific ethics form, they can go ahead with another 15 minutes that you use for research.
Correct.
Same scanner, different scanner.
Usually same scanner, to be honest.
And how does that conversation go about with the patient? What do you tell them?
They receive essentially an information leaflet at home before the MRI scan, so they are already informed in some way. Then we are there to answer all the questions, and most of the patients, I have to say, are happy. The claustrophobic one are usually not happy to stay 15 minutes extra, I have to say. But they're happy, for example, if we use the images for research and teaching purposes, which is one of the other.
So they can decide not to go ahead with the 15 minutes, but they can allow you to use the images.
Yes.
Okay.
Then we ask them if you want to come back, like, for example, what we're doing for the 055. So just come back for another scan on a different machine.
Okay, I don't want to sound aggressive. I will try to be very cynical. So you're meaning that the research radiographer, part of their task would be still scanning patients, mostly, let's say 99%, but you will run research sequences, you will approach patients like recruit them on board for research purposes, and also like liaising with a multidisciplinary team of like engineers. Is this what you mean?
Yes,
like,
correct. And
yeah.
then part of, I think, of as soon as you get like a bit of an expert in cardiac is also give your input regarding the research,
That's
how
what I
you
was
can
gonna
improve
ask.
it
Okay.
and everything
Yeah,
else.
so
So
that's what I
actually-
wanted to know. Yeah.
Do you actually write
contribute.
articles
Yes.
as well? Do you guys write
oh
articles?
yeah.
So you
Yes.
participate on those articles.
Correct.
You actually have your name on it.
Yes.
I think that's important because
That's
most of these articles never have the radiographer's name, and I think it's essential that that work that you do is replicated on those papers
Absolutely.
I actually want to claim something about this to whoever is watching this podcast. Guys, we need to do more, because I think our profession is massive and has a huge importance, and we need to contribute a little bit more in research, as Filippo is doing
Absolutely, yeah.
probably. I think we need to put like the name of radiographers a little bit more in papers, because we see a lot of names from obviously clinicians, scientists, but then radiographers, you know, they contribute massively. It's not just because we perform the research sequence that we are not like contributing in any way, because I mean, he just explained us the recruiting part, guiding the
Yeah, you're doing most
researchers.
of the
So, yeah, I think-
groundwork, basically.
Yeah, so I think you're definitely the body that allows this.
You have to need to, yes, exactly. We have like a very good team over there of researchers which are always willing to put us down in the name of the paper. So as a second name, third name, obviously, but yes, it's good.
Yeah.
And then obviously you can publish something on your own, like ACMR is there for this at this
Yeah, I
point
think
with the
that's
technology
truly insane. I
track
think
and
it's important.
everything.
How do we go about that? If I want to publish an article,
this is
for
what I
example,
wanted to
I'm
ask.
writing an article now about remote scanning.
Mm.
How can I just publish it? Or it's just cardiac, for example?
The ACMR is mainly concentrating on cardiac.
Cardiac,
But what we each year essentially we ask for abstract paper
Yeah.
or report cases or something similar, and then we review, and then the best one essentially are gonna
So
come
my
over to the
my
conference.
article is about remote scanning, but also pointing towards contrast injections, cardiac, breast biopsies, things like that. The heavy
I
stuff.
know you wanted to talk about this. You
Heavy-
wanted to talk
heavy-
about
heavy
this
stuff.
from the very beginning. Cardiac remotely, say it.
Exactly.
Say it.
So I want to ask you, what you think about this, like doing cardiac remotely, and,
Wow, that's
and
a question I
publishing
wasn't
an
ready
article
for.
about doing it.
People are gonna hate you, man. You always want to speak about remote scanning. Yeah, let's speak about remote scanning.
I think I mean, the technology is there to do remote scanning. That probably you know better than me at this point. I think it's feasible, to be honest. I don't see why not. You need to have someone, obviously, at the hospital itself, just to in case the patient is not feeling well for the injection and everything else. But and as I said, instructing the patient and all. It's
Filippo, listen to me. How can you do like a stress perfusion
I
remotely?
have a doubt about that too.
To be honest,
It scares me a bit.
I mean, if scanning is just planning, you can easily do that remotely, I think. Because there is no reason why you need to be on site for that. It's obviously included, but you need to have someone over there for injecting
Like a
contrast,
cardiologist, obviously, yeah.
starting the
That's a good
medication.
question, actually. Do you scan with a cardiologist or a physician next to you?
Yes.
Or you do scans by yourself?
No, we scan with the cardiologist or physician next to us.
Okay.
They are not interfering at all with the scanning.
So they are
Essentially,
just
they are
there.
reporting.
Okay.
But it is always useful to have them, because if you have any doubt, if maybe spotting something, that they can obviously advise what to do. At some point, you get to the level of expertise, they ask you what to do in that case.
Yeah, that's what I was going to
but-
ask, if you feel like sometimes is an issue about trust, or if it's just because they have to be there for you. I'm asking this because where we used to do cardiacs, some of the doctors would like to sit next to us and basically guide us, even if I know how to do it. Some of them don't bother at all. They just say, send me the images. So what's your experience in terms of that? What
But-
do you prefer and what do you do at the moment?
I think having a doctor next to you is always useful. But first of all, for help in general, and then I think my level of knowledge in cardiac is there because obviously being always very close to a doctor, because they teach me what they want to see. I mean, one of the main things for a radiographer is knowing what the radiologist or the cardiologist want to
What
see.
they want,
So without that, it would be like, okay, I've done these images. Is it correct? Is not correct? I don't know what's actually are the parameters to say that. Then obviously learning about diagnosis as well. So I can see there is like a potential myocarditis over there. So as a radiographer, I can cross-cut it. So avoiding the question from the doctor saying, oh, you should cross-cut that part there, and just like do that on your own. That's another reason why I think having them next to you, it's important.
It's important, yeah. And for you to learn as well, right?
Yes,
Even if you're very experienced, there's always
yeah,
something different coming
absolutely,
every
yes.
day. And they can tell you this is that, or you should do it this way, and you learn it that way. Yep, I agree. I think
I have to agree, and I think one of the huge advantage of working like in an hospital like this one, so a university hospital, is the fact that you liaise with a lot of different professionals. So you will get a little bit of the background, the skills, and the competency from everyone. So you will absorb. I mean, working in a small clinic, it obviously has many benefits, but sometimes being exposed to such a massive environment will allow you to get a little bit more from the others every time. So yeah, it's pretty interesting about it.
Can I? Sorry.
Go ahead.
You were
No.
going to say something.
No, same things for researcher at the same time, because obviously we have the researcher and the fellow, the cardiologist next to us. So obviously we learn a lot from the researcher as well on how to prove sequence and
In terms of researching, do you have a research program that you need to follow? Or there's, for example, this week we're going to research about this sequence. Do you have something planned for the year?
This should be, I think. It depends a lot, essentially, because obviously, there are conferences and time for submission. So that's the big moment in which all the researchers are quite a lot at the machine. And then there are moments which, like, for example, 3 weeks ago, it was madness, I think, in the hospital, because there was the approaching of the international SMRM is called, the conference. And then while at the moment they're very quiet because they're developing the sequence again, analyzing the data and everything else. So it's just
so there's always those periods of the year that you know is going to be busy.
Every time you approach like a massive conference, everyone will be, this is
publication time. So then they're all there. But yeah,
I would like to ask you one more question, and this is going back a little bit to the fact that you work with 4 different B0 fields. Imagine you are the CEO and you're opening a new clinic, cardiac clinic only. Which you have to buy 2 scanners. Which ones would you buy and why?
For cardiac at the moment, I would say 1.5.
So you would buy 2 1.5 scanners?
No, 1.5 and 3T.
And 1 3T.
Okay, so you will keep the combination.
Yes.
Okay,
It's an
this is
interesting
pretty
answer, right?
interesting
Yeah.
answer. Yeah. So
what would you scan in one and the other?
Well, 1.5 for a pacemaker, general scan and everything. 3T, as I said, for stress mainly. It's one of the best machines. We are developing 40 flow as well at some point. They are in development, 40 flow, which are amazing for congenital patients.
Have you tried it already? No. You're just
We
developing
tried. We tried. They are very long in the acquisition at the moment, so they're trying to shorten it a little bit. But it's very good for congenital, because in congenital you need many flow to see that all the veins and artery are actually pumping the right volume, essentially. So
That's what I was going to ask you.
we have one sequence instead of like 6 or 7.
What the 4D flow is bringing back to the game? What is it bringing for the cardiologist in terms of diagnosis tools?
From congenital perspective, but also for adult, it's just like you have one sequence in which you can see the whole flow. So if you suspect, like, for example, any problem with the aorta, you can see the whole aortic arch, descending, ascending aorta. But if you want to see like pulmonary and everything else, you have just one sequence, done everything, and then they can just analyze it. And it's also for them, in the moment in which they do the analysis, it's seeing exactly where is the peak, and then try to understand if there is an occlusion, something which is not working or something which is not connected properly, and everything is very good.
Wonderful.
Well, I have to say, well done, Samuel. That was a great question, and actually,
It's not mine, actually.
But I have a question as well, and this will be the question that we're going to ask to every single guest will come here. So now the others will say, "Wow, what is this question?" And instead will be. So here is my question, man. Just be ready. Why MRI?
Oh, good question.
We didn't prepare it. Why MRI?
No, exactly. Next time I'm
So
going to
you
ask
can take a little bit of time.
okay.
I know it's a very broad question, but why MRI?
It makes me think as well, why MRI?
Why MRI?
Well, first of all, I think because you don't expose patient to radiation, and that's obviously very positive and create like much more opportunity. We as a center, we scan also fetal or pregnant woman, which obviously on
That's
CT
another
scan,
conversation that we need to have
later. you it's not really recommended to do on CT or X-ray. MRI give you like the opportunity to see most of the tissue or bone and everything else at the end of the day. Cardiac, it's really good in MRI, is developing. Some sequences are still better in CT. I have to say, I can say cardiac it's perfect, but we are going there. And then it's a very interesting field, I think, for all the research part and all the opportunity you can have compared to other modalities, to be honest.
Yeah, I think that's
MRI is
where
in development, I think.
Where Julian wanted to get is why MRI for you. So you're just telling us why, but I would like to know more. What made you choose, like, at the beginning of your career, instead of going for CT cardiac? Why MRI for you then?
As I said, well, the honest answer, if I have to reply, back in time was just like, oh, I have this opportunity to go to London. It's amazing. Let's go. I mean, at 20,
that's what happened with me,
I was like,
as well, yeah.
MRI is London.
It's London.
Why not?
I'm 20 years old. I'm in London. Amazing. Yeah, let's go. Right now, I think, as I said, because they offer a lot of opportunity for research. So it cannot be just the usual standard job in which you put the patient on, you just position your slices and then you scan the patient. MRI is in development. There is a lot of brain that you can put down.
So you connect MRI with research. And I think this is great, to be honest, because I think many of us that work in this field, they think they are two separate words. Instead, I think MRI and research, my God, I think what is going to happen in the future is going to be massive. So let's just be ready. I think if you might have a couple of thoughts for us, you just want to leave us, you can write it here. Do you want to introduce a little bit?
So basically we're doing this with all of our guests. We just want some comments for everyone that comes here for Everything MRI, which is us. So we just want you to take your time and just write us a nice message. We'll post it with a picture of ourselves later on.
Okay.
And
nice.
we would like to give you 2 more minutes to just tell us if you want to say anything about any courses, anything that's coming up, or anything that you're doing or you're planning to do. Just tell us what's going on with Filippo.
If you have any questions as well that you want to ask.
No, I think what you've created, guys, is amazing, to be honest. Very interesting, and thank you very much for the invitation. It's been a pleasure being in here.
It's our pleasure.
And courses, there are plenty of courses, I think, regarding cardiac MRI. So just look online, you're gonna find something. As I said, opportunity for SMR as well if you want to learn something. This year also is in London, so it's in the UK. So
boom!
I have to say, it's across my hospital, unfortunately.
So
not
there you go. They
but
can just pop in and say hello.
Exactly. And then, just keep curious, essentially. Just like try always to go above the knowledge you have in some way. So just not thinking, oh, I learned this, so I know how to do my job. Yes. I mean, one of the future things that I'm aiming to become is like a reporting radiographer. So learning also to do the reports.
Reporting cardiac?
Cardiac, yes.
Wow.
Amazing.
And so it doesn't stop, essentially, if you don't want to stop. If you can have in your job and do your scan and go home if this is what you like, but if you want to develop more, just like take any opportunity and be curious.
You convinced me. Okay, for me, you are my cardiac MRI Steve Jobs. I mean, I can go away, it's all done.
I love what you said about being curious, because when we're kids, we have that age of the whys. Why this, why that? And once we grow old, we stop asking questions. And I think it's very important what you're saying. Be curious. Yes. Just ask questions. Try to find the knowledge that you need. So thank you for that. I think it's a very good advice, not only for us, but for everyone at home.
I think,
yeah.
Well, thank you, Filippo.
Thank you very much, guys.
We'll leave it this. Take your own time. And then we will continue discussing about cardiac anyway, because I think it's a growing field. We will learn more in the near future. But in the meantime, I think this was like a very comprehensive discussion. So again, thank you for your time.
Thank you.
And enjoy over here.
We appreciate you. Thank you so much for coming.
Thank you so much. Thank you, guys.
Thank you.